Okay, let's think about the heart for a second. That amazing engine in your chest, just constantly working.
Day in, day out. Absolutely vital.
But what happens when part of it, like a valve, isn't quite working right? It can really affect
It
things.
certainly can. And
Yeah.
today we're looking at one specific issue, mitral regurgitation, or MR.
Right, MR. That's where the mitral valve, the one between the left atrium and left ventricle, it doesn't close properly.
Exactly. So blood flows backward, which puts extra strain on the heart. You might feel breathless, tired.
Yeah.
It can lead to bigger problems down the line.
So in this deep dive, we want to understand a specific treatment for MMR called MitraClip therapy, what it could mean for you.
hmm And really explore what it is, how it works, the pros, the cons.
And the insights we're exploring today, they come from Dr. Reza Lankarani. He's a general surgeon and surgical innovation lead at Surgical Pioneering Newsletter, Surgical Frontiers, and Pioneering Tech Transforming Surgical Care.
Yes, his work gives a really comprehensive overview. Helps us understand the device, the procedure, who it's for, and how it, stacks up against traditional surgery.
Okay, let's start there then. What exactly is a MitraClip, in simple terms?
Well, fundamentally, it's a very small clip, tiny, actually, and it's used in a minimally invasive procedure.
Minimally invasive, meaning no big surgery.
Right. The procedure is called transcatheter edge-to-edge repair, or TEER for short. Instead of opening the chest, this little clip is delivered through a thin tube, a catheter.
Okay.
So the whole idea is fixing that leaky mitral valve without needing open heart surgery.
So how does this tiny clip actually, stop the leak?
It's quite clever, really. The design was actually inspired by a surgical technique called the Alfieri stitch.
Alfieri.
So the MitraClip basically grabs the two flaps or leaflets of the mitral valve that aren't closing properly.
It physically clips them together.
In the middle, yes. By clipping them together, it creates two smaller openings instead of one leaky large one.
Ah, I see. So it doesn't seal it completely, but makes the opening smaller and more controlled.
Precisely. And that significantly cuts down the amount of blood leaking backward, the regurgitation.
That sounds like a really elegant solution. And is it used much?
Oh, absolutely. It's actually the first FDA-approved transcatheter therapy specifically for repairing the mitral valve.
First one. Wow.
And it's been used in, I think the number's over 200,000 patients worldwide now, so it's definitely a significant treatment option.
Okay, 200,000. That's substantial. So we know what it is. Now, for you listening, who is this actually for? Who's a good candidate?
Well, there are mainly two groups we think about. First, patients with what's called primary or degenerative, MLR.
Degenerative meaning the valve itself is the problem.
Yes, there's a structural issue with the valve leaflets themselves. For these patients, MitraClip can be a great option, especially if they're considered too high risk for traditional open heart surgery.
High risk because of it.
Things like advanced age, being generally frail, or having other serious health issues, severe COPD maybe, or kidney failure, things that make major surgery much more dangerous.
That makes sense. A less taxing approach for more vulnerable patients. What's the second group?
The second group has secondary or functional missed RF. Here, the valve itself might be okay structurally.
But it's not closing right anyway.
Exactly. It's usually because the left ventricle, the main pumping chamber, is enlarged or not working properly, often due to heart failure. This pulls the valve leaflets apart.
Okay, so it's a consequence of another heart problem.
Right. And the criteria here are pretty specific. It's usually for patients who still have heart failure symptoms despite being on the best possible medications, what we call optimal guideline-directed medical therapy, or GDMT.
Still symptomatic even with meds.
Yes. And typically their heart's pumping function, the ejection fraction, or LVEF, is moderately reduced somewhere between 20 and 50%. And the size of the ventricle, the LVESD, shouldn't be excessively large, generally 70 millimeters or less.
Got it. So specific criteria for that functional MR group. Now, conversely, who is MitraClip definitely not suitable for?
There are clear contraindications, yes. For instance, if someone has an active infection in the heart valves, that's called endocarditis, that's a no-go.
Right. You wouldn't want to put a device in during an active infection.
Absolutely not. Also, rheumatic mitral disease, which is valve damage often stemming from rheumatic fever, is generally not treated with MitraClip.
Okay.
And if there are blood clots, thrombus, in the heart itself or in the large vein returning blood from the lower body, the inferior vena cava, that would also rule it out.
Makes sense. Infection, clots, certain types of valve damage, anything else?
Yes, allergies are important. If you're allergic to the materials in the clip nickel, titanium, polyester, you shouldn't have it.
Okay.
Also, patients need to be able to take blood thinners, anticoagulants, or antiplatelets after the procedure. If they can't tolerate those for some reason, that's a problem.
Right, the post-procedure meds are crucial.
They are. And then there's some anatomical reasons too. We mentioned rheumatic disease, but also things like clefts in the leaflets, or if the main issue is at the corners, the commissures of the valve.
And what about the heart function we mentioned earlier?
Yes, if the left ventricle is very severely weakened, say an LVEF below 20% or an LVESD greater than 70 millimeter clip, MitraClip generally isn't recommended.
So too weak is also a contraindication.
Correct. And as we said, active clots or infection, also specific anatomical things like not having enough leaflet tissue for the clip to grab onto, or if there's way too much calcium buildup on the valve, that can make it technically difficult or impossible.
And what if your MR isn't that bad?
Good point. If you're asymptomatic, so you don't have symptoms, or if the MR is only mild to moderate, what we call grade 2 or less, then typically MitraClip wouldn't be considered necessary.
Okay, that paints a pretty clear picture of who might be a candidate and who wouldn't. Let's get into the procedure itself. How does this tiny clip actually get to the heart?
It's quite remarkable, actually. It's done minimally invasively, as we said. Usually access is gained through the femoral vein, a large vein in your leg.
Through the leg. Wow, so no chest incision at all.
No chest incision, no need to stop the heart. A catheter, that thin tube, is inserted into the vein.
And then guided up to the heart. How do they see where they're going?
They use sophisticated imaging,
Mm-hmm.
primarily fluoroscopy, which is like a real-time X-ray movie,
Okay.
and transesophageal echocardiography, TEA. That's ultrasound. But the probe is passed down the esophagus, which sits right behind the heart.
So it gives really clear pictures from close up.
Extremely clear, detailed images of the heart valves in action. It's crucial for guiding the whole procedure.
Okay, so the catheter's in the leg vein, guided by imaging. How does it get to the left side of the heart where the mitral valve is?
Ah, good question. The catheter first enters the right atrium. To get to the left atrium, the team performs what's called a transeptal puncture.
Puncture. That sounds a bit dramatic.
It's very controlled. The septum is the wall between the right and left upper chambers, the atria. They create a tiny, precise hole in that wall. Think of it like carefully opening a small door to pass the catheter through to the left side.
Okay, a controlled crossing. So now they're in the left atrium near the mitral valve. What's next?
Right. The delivery catheter, carrying the MitraClip, is advanced towards the mitral valve. The clip itself starts closed. It's then carefully opened and positioned right above the leaky part of the valve, ready to grasp the leaflets.
That sounds incredibly precise. How do they know they've got it just right and that it's actually working?
That's where the real-time T imaging is absolutely vital. The doctors are watching constantly. They position the clip, grasp the leaflets, and then they assess.
Assess the lead.
Yes, they measure how much the regurgitation has reduced. They want to see a significant improvement. But they also have to be careful.
Careful of what?
Of creating the opposite problem, mitral stenosis, or narrowing of the valve opening. The clip brings the leaflets together, which is good for the leak, but you don't want to make the opening too tight.
Ah, right. It's a balancing act.
Exactly. They aim for a pressure gradient, the pressure difference across the clipped valve, of 5 millimeters of mercury or less. That generally indicates there isn't significant stenosis.
Okay, so reduce the leak, but don't tighten the valve too much. Once they're happy with the position and the result,
Once they've achieved that target reduction in MR, and they're confident the stenosis risk is low, the clip is deployed, released from the delivery system. It stays there permanently, holding the leaflets.
and then they just withdraw the catheter.
Exactly. The catheter system is carefully removed. The whole procedure typically takes maybe 1 to 3 hours.
1 to 3 hours. That's pretty quick for heart valve repair.
It is. And the hospital stay reflects that too, usually just 1 to 3 days.
Amazing, compared to open heart surgery.
Oh, vastly different recovery. This is typically done under general anesthesia, usually in a cardiac catheterization lab, a cath lab.
Okay, so faster procedure, much shorter stay. Let's talk about the benefits then. What positive outcomes are we seeing?
The outcomes have been really encouraging, especially in certain patient groups. The big coapt trial, for example, looks specifically at patients with that secondary functional MR.
The ones with heart failure.
Yes. And it found MitraClip significantly reduced hospitalizations for heart failure by something like 47 to 51%. That's huge.
Almost cutting hospitalizations in half?
Pretty much. And it also lowered the risk of death by about 33% over 2 to 3 years compared to just medical therapy.
Wow. So improved survival, too, in that group.
Yes, it really showed that for these patients, this less invasive approach wasn't just about faster recovery, it genuinely improved major outcomes, staying out of hospital, living longer. That's a big deal.
Absolutely. What about longer-term results, maybe for other types of MR patients, too?
Well, the Everest 2 trial looked at a broader group. It showed that the reduction in the leak was pretty durable, lasting out to 5 years.
5 years is good durability.
And importantly, they also saw some positive changes in the heart muscle itself, reverse LV remodeling, meaning the enlarged ventricle started to shrink back towards a more normal size.
That's a sign the heart is under less strain.
Exactly. At 1 year in that trial, about 82% of patients were alive, nearly 80% were free from significant MR, and over 90% hadn't needed another operation on the valve.
Those are solid numbers. And symptoms. People felt better.
Definitely. Sustained improvement in symptoms like shortness of breath. The effectiveness seems quite durable, holding up for 5 years in many cases.
Beyond the hard clinical data, what about just quality of life? How people feel day to day?
That's a really key benefit. Studies show patients getting MitraClip are about 2.5 times more likely to see a significant improvement on quality of life scores, like the Kansas City Cardiomyopathy Questionnaire, the KCCQ.
2.5 times more likely.
Yeah. And specific symptoms like shortness of breath and fatigue improved in, I think it was 95% of cases. That's remarkable.
Huge impact on daily living.
Absolutely.
Yeah.
Patients often move to a better NYHA functional class, meaning they can do more physically without symptoms. It translates to real, lasting improvements in how they live their lives.
It really does sound potentially life-changing. Now, we keep comparing it to open heart surgery. Let's dig into that comparison a bit more. What are the main advantages of MitraClip over surgery?
Well, for patients deemed high risk for surgery, MitraClip generally comes out ahead in terms of safety, lower risk of mortality in that group.
Okay, safety first for high-risk folks.
And the recovery, as we've said, is just night and day. Hospital stay of 1-3 days versus potentially a week or more.
Much faster back home.
And much faster back to normal activities. Days or weeks for MitraClip versus potentially weeks or months of recovery after open surgery, which involves cutting the breastbone, going on the heart-lung machine.
Right, it's a much bigger operation.
Much bigger. MitraClip avoids all that. Less pain post-procedure, too. And for those high-risk patients, especially if their heart function is already reduced, there seem to be lower rates of complications like major bleeding or stroke around the time of the procedure itself with MitraClip.
Less risky during the procedure itself for certain patients.
Yes. And importantly, compared to just sticking with medical therapy alone for secondary MR, MitraClip cuts that risk of heart failure hospitalization significantly. And even long-term survival in high-risk patients seems pretty comparable between MitraClip and surgery.
So a really strong alternative, especially if surgery looks too risky. But like any procedure, there must be downsides, potential risks.
Of course, no procedure is risk-free. With MitraClip, during the procedure itself, there can be issues related to the catheter insertion in the leg.
Reg bleeding.
Bleeding is the main one, sometimes needing a transfusion. That happens in maybe 3 to 13% of cases. Less commonly, you can get a small hole between the heart's upper chambers, an atrial septal defect from the transeptal puncture, or some fluid buildup around the heart called pericardial effusion.
And problems with the clip itself during placement.
It's possible, though less common. The clip might only attach to one leaflet that's called single leaflet detachment, maybe 1-3% risk. Very rarely, the entire device could dislodge and travel, embolize.
Okay. What about issues that might crop up after the procedure's done?
Well, we mentioned mitral stenosis if the valve becomes too narrow after clipping. That's why they monitor the pressure gradient carefully.
Right, the 5 millimilli Hg target.
Exactly. And sometimes the clip might not reduce the leak as much as hoped, leaving some residual MR down. Overall, the rate of any significant complication within the first 30 days is reported somewhere in the range of 15 to 19%.
15 to 19% within 30 days. It's important for people to know those numbers. Are there other specific risks we should mention?
Yes. During placement, though rare, there's a risk of actually puncturing the heart wall atrial perforation or a more severe fluid buildup, causing pressure on the heart, cardiac tamponade. Damage to heart tissue or forming a clot that travels, and embolism are also small risks.
And issues at the leg insertion site?
Besides bleeding, you could injure the femoral artery. We also mentioned single leaflet detachment. That's probably the most frequent device-related issue, often requiring repositioning or adding another clip. Clip embolization or clot formation on the clip itself are rare, but serious. And that procedure-induced mitral stenosis is always a possibility.
What about longer-term things or reactions to the device?
Allergic reactions to the clip materials, it's often a cobalt chromium alloy, or to medications are possible.
Right.
Long-term, any invasive procedure carries a small general risk of stroke.
Okay.
And we've learned that certain factors predict worst outcomes. Higher levels of a blood marker called proBNP before the procedure seem linked to higher mortality risk afterwards. Also, having more residual MR left after the procedure isn't ideal for long-term outcomes. And over time, some patients might need another intervention on their mitral valve.
What about more common, maybe less severe side effects?
Things like bleeding or bruising at the leg site are relatively common but usually manageable. Acute kidney injury can happen, sometimes linked to the contrast dye used for imaging, and temporary irregular heartbeats like atrial fibrillation can occur.
And any really rare but very serious things people should just be aware of?
Very rare, but an infective endocarditis, an infection settling on the valve or clip, is a risk. And cardiac tamponade, if it happens, is a true emergency.
Okay, so a definite risk profile to weigh against the benefits. Let's revisit that comparison with open heart surgery again, pulling it all together. How do they truly stack up on key metrics?
Okay, let's try to summarize. Mortality and safety. MitraClip generally safer for high-risk patients. Surgery is riskier for them, but might be preferred for lower-risk patients. Perioperative complications like bleeding seem lower with MitraClip in certain high-risk groups.
Right. What about actually fixing the leak? Efficacy.
Surgery usually achieves a more complete reduction of MR, less residual leak immediately after. MitraClip provides meaningful, often durable reduction, but maybe not always quite as complete as surgery. And some data suggests cardiac function improvement might sometimes be better after surgical repair.
Okay, surgery might be better at the primary goal of stopping the leak completely.
Potentially, yes, but then there's recovery.
Big difference there, right?
Huge difference. MitraClip, faster recovery, shorter hospital stay, back to life quicker. Surgery, much longer recovery, weeks to months.
And long term, how do things look years down the road?
This is where it gets nuanced. Surgical repair is generally considered more durable anatomically, less chance of the leak returning significantly over many years.
So surgery might last longer.
That's the general view. With MitraClip, there seems to be a higher rate of recurrent MR over time and potentially a greater need for reintervention later on. Both improve symptoms, but MitraClip might be particularly good for relieving shortness of breath. Long-term survival rates, again, seem similar in those high-risk patients where the comparison is most relevant.
So it sounds like MitraClip is often about balancing safety and symptom relief, especially in high-risk patients, even if it means accepting potentially less complete or less durable MR reduction compared to the gold standard surgery.
That's a very good way to put it. For lower-risk patients needing the most durable fix, surgery often remains the standard. For higher-risk patients, MitraClip offers a valuable, safer alternative focused on improving symptoms and quality of life.
It really highlights how crucial patient selection must be. How do doctors decide?
It's absolutely key. It requires a multidisciplinary heart team, cardiologists, surgeons, imaging specialists all weighing in.
A team approach.
Yes. They look at the surgical risk, the exact anatomy of the mitral valve from the T images, the severity of the MR, the patient's symptoms, their overall health. That left ventricular function we talked about, the LVEF, 20-50%, LVESD, 70 millimeter for secondary MR are examples of inclusion criteria. And specific valve features, is there enough tissue? Is it too calcified? Where exactly is the leak originating? Proper selection based on all these factors is what really drives success and ensures patients get the long-term benefits.
It's clearly a very careful, personalized decision. Has the technology itself changed much over the years?
Oh yes, definitely. We're now onto the MitraClip G4 system. It's the 4th generation.
G4, what's new?
Several things. It offers 4 different clip sizes now, which gives more options to better match the patient's specific valve anatomy.
More tailored treatment.
Exactly. It also has something called controlled gripper actuation. This lets the operator grasp each leaflet more independently and precisely.
Finer control during placement.
Right. And there's enhanced integration with the imaging systems, the echo, which helps with precise positioning. These aren't trivial changes. They aim to address limitations of earlier versions and potentially improve outcomes further.
Sounds like continuous improvement. Okay, last piece. After someone has the MitraClip procedure, what's the typical follow-up care?
Post-procedure care is pretty straightforward but important. Patients usually go home on antiplatelet therapy, typically aspirin lifelong, and another drug like clopidogrel for about a month. sometimes longer.
To prevent clots on the clip?
Precisely. If they have atrial fibrillation, they'll likely need standard anticoagulation for that too. Activity-wise, usually just avoiding strenuous stuff for about a week while the leg site heals.
Okay.
Then follow-up is key. An echocardiogram is usually done around 30 days post-procedure and then typically annually after that.
To check the clip and the valve function.
Yes, make sure the clip is stable, the MR reduction is maintained, and there's no significant stenosis.
Yeah.
They also monitor for any delayed complications like bleeding or arrhythmias. Pain is usually minimal, but those regular echo checkups are crucial for long-term monitoring.
That gives us a really thorough picture. So, summing up, MitraClip is this minimally invasive way to treat mitral regurgitation, a real boon especially for patients too risky for open heart surgery.
Right. Big advantages in safety and recovery for that group, though maybe not always as complete or durable a fix as surgery might offer for lower-risk individuals.
And patient selection by that heart team is just critical for getting good results.
Absolutely paramount.
Okay. And again, a reminder that the information we've unpacked today comes from material provided by Dr. Reza Lankarani, General Surgeon and Surgical Innovation Lead at Surgical Pioneering Newsletter, Surgical Frontiers, and Pioneering Tech Transforming Surgical Care. Now, thinking about all this, it's amazing how far minimally invasive heart treatments have come.
It really is.
So, looking ahead, you have to wonder, what other groundbreaking, minimally invasive cardiac therapies might be just around the corner, and how will they continue to change the landscape of heart care for all of us?
That's the exciting question, isn't it?
Yeah.
Definitely something to think about.